Hello everyone, welcome to my YouTube channel. Last time we discussed about Haemorrhage as it regards to IT guidelines. One of the reasons why I made that video before deciding that we should look at major hemorrhage protocol was because it is always important to know that in a case of emergency, that you understand where you can do electronic issue or where you may have to do serological cross-match. Basically, that was why I made that video, so that you can have understanding. And again, so that you will also know that when you go for interview and they ask you about guidelines in blood bank or blood transfusion, you can have something to say. And I have said also that I'm going to go through a lot of guidelines in blood transfusion. But today, I want us to look at major hemorrhage activation protocol. And that is what we call MHP. So M means major, H means hemorrhage, then P means protocol. Anyway, before we move on, my name is Dr. Emmanuel Obodo. I've been working in the UK as a specialty biomedical scientist, and I'm a lecturer in biomedical science here in the United Kingdom. So yes, let's get into it. Remember that it is not the lab itself that activates major hemorrhage. It is the ward, maybe from accident and emergency or from maternity unit, from any ward. They are the one that will activate major hemorrhage. But once they activate that major hemorrhage, okay, then there's a protocol, okay? There are things that you're supposed to do as a biomedical scientist. I'm going to try to practicalize this where possible. And I think I've said that already on my previous video, but I want to give, so we have what we call a blip. So that blip, you carry it, okay? Someone in blood bank will carry it. So what that blip means is that you can be assessed in a case of emergency. It means that the ward can be able to get in touch to you once there's emergency. If there is anything that is emergency or urgent, you will get a blip, okay? So sometimes emergency can differ. So you can have emergency because somebody just want the result now. That's a different thing. You can also have emergency in terms of somebody wants to double check. This sample is urgent. I want to make sure, have you received it? That's different. So such a thing, you might just have a blip, like the blip will just make a sound. And then you check the number, then you see a number that will show you the extension number. Then you call the extension number. Then they will ask you any question. But when it comes to major hemorrhage activation, what will happen is that it will make a long noise. Okay, you might hear something like beep, 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 beep. So once that noise is made, it will not just stop there. After that noise, it will tell you something like major hemorrhage activated. Then it will also tell you that where that major hemorrhage has been activated, it might say A and E resource, or it can tell you something like maternity. Whichever word that activates that, it will tell you that. It will give you that information. So once you hear that sound, you as a biomedical scientist now know that this is a major hemorrhage activation protocol. Now there are things you need to do. One of the things you are going to do then is to call that extension number. Once you call that extension number, there are a lot of things that you need to do. But a good biomedical scientist, once you have heard that, you try to log on onto your system to get ready, because you're going to be asking some questions. And I'll get into that when we get to that point, okay? But what I want you to know that it is not the lab that activates a major hemorrhage. It is the ward that activates a major hemorrhage, okay? So we'll go into detail of some of the questions you may need to ask them once you call them. But let's move on to this. So why should a major hemorrhage be activated? Why are they activating it? One of the things I want you to know that once a major hemorrhage is activated, something is going on, and what is going on is most likely to be bleeding. Somebody may be bleeding, okay? So, and because somebody is bleeding, maybe the bleeding is serious. That is the main reason why they would activate a major hemorrhage. Now, another thing I'm going to let you know that sometimes a major hemorrhage activation may not also come from the blip. Okay, sometimes it can come by a phone call. Somebody can just call you and say they are activating a major hemorrhage. Okay, then the same procedure will also happen. So in major hemorrhage activation, it can come on the blip as the sound I mentioned, or if you don't hear the sound, or maybe if it doesn't come on that blip to make that sound, it can also come by a phone call. Once that major hemorrhage has been activated in any other way, whether by blip or by phone call, okay, what you then have to do, you ask for the patient detail. So there are questions you need to ask, because remember, you are going to be issuing a blood. Okay, when you are going to issue blood, you need to know at least what to be issuing. You see it now. So you need to know the patient. Remember that, which we are going to still mention in detail. In some cases, you don't even know the patient. So that's fair enough. But what I'm trying to say that once that is activated, you ask for the patient details. Okay, patient detail you may need to ask is something like, what is the NHS number, or what is the hospital number? Once you type in the hospital number on the limbs, it should bring up all the details that you need, okay, to make a decision regarding that patient. So that's why you can see, have I known this person? Do I have a current group? Is there any antibody history? Any of those information that we've mentioned in the past, that is where you can see that information, because that will help you to make a decision. What will I be negotiating with the ward? Okay, is there electronic issue, or is it a cross match, or can they be able to wait? Can they not be able to wait? If they can wait, what do I do? If they cannot wait, what do I do? Okay, so this is why that is important. Now, on the major hemorrhage protocol, there's a form most times. So once that is activated, you start filling the form. One of the things you fill in that form is at the time of that major hemorrhage activation. You will also go to fill in, was the major hemorrhage activation, was it by a phone call or was it by a blip? Okay. Then you also need to know the word that activated that major hemorrhage, okay? Which word activated it? Then you also need to know who is the communication lead. The communication lead in that word is somebody that anytime you phone, if you want to give them any information or they want to give you any information, so you know the person you'll be asking for the name. For example, when you are filling the form, you ask the person that you are on the phone with, who is the communication lead? In most cases, the person will tell you he's the one or she's the one. So once they tell you that it is this person, what you then need to do, anytime you call, you ask for that person. So that person is a communication lead, okay? Then another thing you might need to know is that who is the consultant looking after that patient. You see it now. So these are the information that you are going to fill in on that form, of major hemorrhage activation protocol in the lab. You can also ask something like, who is a team lead, okay? Then you can also ask the reason for activating the major hemorrhage. Sometimes they may tell you something like the GI bleed, as the case may be, okay? Now, all of this information, you fill it in, okay? But you don't need to wait to just for you to have overview information. Sometimes, if it is a serious major hemorrhage, what you do is to focus mainly on issuing a blood product. Then later, you can call that very communication lead and ask some of these details. But you must at least know the patient detail to know who is this patient, what do we know about this patient, and so on. But if after everything you think, no, I can't really wait to start asking who is the communication lead, who is this, who is that, depending on the situation, you might say, okay, that is fine. You can start issuing the blood where possible. We'll go into detail with this. Before later, you can then ask that communication lead some of this information, like who is the team lead, who is the consultant, and all of that, okay? Now, in a major hemorrhage, it is important, again, for us to recap something, okay? I want you to know that, so in major hemorrhage activation, you are going to be issuing blood products. So what are the blood products that you are going to be issuing in most cases, okay? Red blood cells, FFP, which is fresh frozen plasma, okay? Then platelets or cryoprecipitate. These are the things that you are likely to be issuing, okay? Now, let me give you a little background. If somebody is bleeding, what do you think will happen to that person's system? Obviously, the person is losing red blood cells, right? Good. So that is why you have to, okay, compensate that loss by transfusing the person red blood cells. So that makes sense, okay? Now, but remember that because the person is bleeding, clotting factors will be activated. You see it now? And because clotting factors will be activated in trying to stop that bleed, it may mean that there may be a low amount of the clotting factors, okay, if not replenished, and that is where FFP comes in, okay? And remember that, again, if the clotting factor is being activated, and if to stop the bleed is to be formed by like the clot, as the case may be, that means fibrinogen again will have to be converted to fibrin. You see where cryo comes in, okay? And remember again that platelet plays a role in the blood clotting. So this is why each of these very blood products are very, very essential. But again, it depends at which point do we need them. So once a major hemorrhage is activated, you are going to be giving blood product, red blood cells, FFP, cryo where possible, cryoprecipitate where possible, and platelet where possible. Now, there are things that I know I've mentioned something like emergency scenario, something like that in my previous video. But I thought I should put this in a way that it will make sense. And I want to follow up from our last videos about MHRA guidelines, as regard to electronic issue and all of that. What I want you to know that once a major hemorrhage is activated and you start asking questions, there's a reason why you are asking for that patient detail. One of the things you want to know is that something like, do the patient has a current group? And by the way, let me say this. Once I say a current group, what I mean then is that there's already a historic group. You cannot talk about a current group without a historic group. Does that make sense? So for the purpose of this presentation, once I say current group, just know that there's already a historic group. Okay, good. Where there's no historic group, I'm just gonna focus on historic group. Okay, now, so you need to know, do we have a current group? Okay, so if we don't have a current group, you now ask yourself, do you have a historic group? So that is why you're asking that question. That question will help you, because once they give you the patient NHS number or hospital number, and that will help you to look into that patient to know at least what is the group of this patient. Do this patient has any history of antibody? Does this patient have any historic group? Does this patient have any current group? As the case may be, it will give you overview what to expect. If the patient has an antibody, what antibody does this person have? That will also help to form your decision. You see why you have to ask for that information. So if you go for interview and they ask you, in a case of emergency, which blood will you issue? Or they ask you, if a major hemorrhage is activated, what are you going to do? Let me tell you something. What many people is likely to answer is you will issue O negative blood. Yes, but that is a generic answer. Okay, if you want to give a basic answer, you are right. Of course, in a case of emergency or major hemorrhage is activated, you just give O negative or O positive if it is a man or a woman above childbearing age. That is fair enough. Okay, but if you really want to give a detailed answer, your answer should start by, it depends on the scenario. And we're going to go to each of these scenarios, which of course I've kind of done a little bit before. Okay, but I want to link it here because it's very, very important. Okay, so it depends on the scenario. Number one, does the patient have a current group and no history of antibody? Now, let me explain what I mean. Remember, I said if I say current group, that means the person already has a historic group. Okay, now I'm going to tell you what to do. You tell them, if the patient has a current group and no history of antibody, then you have to do electronic issue. What it means is that you're going to issue a group specific to that patient. As simple as that. Okay, now, but you also need to bear in mind, even if the patient has a current group and no history of antibody, if it's a woman within bearing of age, in all of this is we're saying, in any scenario, you must make sure that you issue antigen K negative blood. That is one of the guidelines in blood bank. Okay, so you say it depends on the scenario. Does he have a current group and no history of antibody? If yes, you give a group specific and you add, however, if it's a woman within bearing of age, I will make sure that the red cell is antigen K negative. The second one is that, does the patient have a current group but history of antibody? Now, if the patient has a current group but has a history of antibody, once that is the situation, you then need to negotiate with the ward, because there's antibody involved. Okay, so because there's antibody that is involved, what you then going to do is to ask the ward, please, will it be okay to wait? The situation, will it allow me to do a serological cross match? Because this patient is not eligible for electronic issue. Now, the ward in some cases will tell you they can wait. If they can wait, what you're going to do is to perform a cross match and issue a compatible unit to that patient. Does that make sense? So now, please note this. If the ward cannot wait, because there is a current group, you have two options to make. You could decide to give a group specific, okay? Now, but also you bear in mind of the antibody the person have. I will explain that in detail. But in most cases, if you don't have confidence to give that group specific, okay, remember this person has a current group but has antibody. If you don't have confidence to give group specific, because for the group you don't have a problem, you know that this person have this group is this group, it is A positive or it is B positive, you are sure that it's a group. What is the problem is the antibody. So you can decide to either issue a group specific, in a case of emergency, if they cannot wait for cross-match, or you can issue your usual O positive or O negative. Now, let me also say something else. Sometimes, remember what we mentioned about the guidelines, IT guidelines and all of that, regarding electronic issue. I said, if you modify any result, once analyzer performs blood group and antibody screening, any manual modification, even if you have any reason for it, let me put it this way, there's a current group, no history of antibody, but even with that current group, you modify the result. You know, like when we talk about a dual population, and you have modified that result. If you modify the result and send it across to the limbs, the person, like I said before, is no longer eligible for electronic issue. So because of that, even if the person does not have any history of antibody, but you have modified the result of the blood group, okay, and antibody screening where possible, you've modified it. Once there's any modification of a result, you then tell them that because you modify the result, you also will need to do serological cross-match. Of course, if they can wait, you do serological cross-match. If they cannot wait, you also you can issue O positive or O negative, like we said, or you can issue a group specific, like I've said, because you've confirmed the group of that patient. Now, let me also ask something here. One of the things I'm going to say here is this. In a case of emergency, be careful. You know, because of that, when they ask you some of these questions, in most cases, the ward is not going to wait for you to do that serological cross-match. Because for them to activate a major hemorrhage, it means that it is urgent. Okay? They are not going to wait in most cases. Now, if you go for interview, they may want to know, do you know what you can do? What can you possibly do to help? You see it now. What can you really do to help? Okay, now what you need to do, for example, if the person has a historic antibody little c, what you then need to do, even though they cannot wait for cross-match, because if you are going to cross-match, you are going to be cross-matching antigen little c negative blood, right? So what you are going to do is this. Even though they are not going to wait, but you know this person has antibody little c, what you then need to do is to try to select a red blood cells that are antigen little c negative. I hope that makes sense, okay? So in a case of emergency, where they are not able to wait for you to do cross-match, please, where possible, consider that antibody the patient has, giving red cell that has that antigen negative, okay? Now, that is, you know, what I'm going to say in terms of when the person has a current group, but there's antibody, or you modify the result. Once there's antibody, or you modify the result, the person is no longer eligible for electronic issue. You have to then do a serological cross-match, okay? Now, remember what I told you, where antibody is present and they are not able to wait for serological cross-match. Remember, I did mention on my previous video that where possible, of course, you might need to let the hematology consultant know. So there's a lot of things I said. I wouldn't want to kind of repeat myself on what I've said on my previous video. The next thing is that you might have a scenario, which is the third one, where there's a historic blood group, meaning there's no current blood group. There's a historic blood group and no antibody. So because there's a historic blood group and no antibody, the person again is not eligible for electronic issue. And if this person is not eligible for electronic issue, what are you going to do? Because there's no any current group. Remember, to do electronic issue, there has to be a current group and there will not be any history of antibody, okay? Good. So there's no current group. This person has historic blood group, no antibody history, but no current group. Again, the same thing is applicable. What you are going to do then is to ask the ward if they can wait, okay, to, you know, for you to be able to do a cross-match, and if possible, can they send you the current group, current sample, so that you can run a blood group and antibody screening. That way you can have a current group. Sometimes they can say, okay, that is fine. Then they will send you sample to have a current group, okay? That way, of course, if you have a current group, no history of antibody, electronic issue, that is not a problem, okay? But if they say they cannot wait, again, it has to be serological cross-match. Okay, I've mentioned 3 scenarios. This is the third one now: a historic blood group and no antibody history. So your problem there now is that the patient does not have a current group. So you now ask for the current sample if they can wait. If they send you current sample and if they can wait, you run it. Then if everything is fine, you do electronic issue. But again, if you see antibody screening positive, then you have to do antibody panel, of course. That means the person is no longer eligible for electronic issue. It then have to be a serological cross-match. Now, if they are not going to wait when there's a historic blood group, no current blood group, and they say they cannot wait, and of course there's no antibody, what you do when you issue that blood, always please ask them to collect the patient's sample before transfusing the patient and send you the sample to run for the current group. The reason being that if they transfuse the patient, when you are doing the blood group and antibody screening, you are assessing both the patient and the donor, and you want to limit that where possible. The next scenario, which is the fourth one, is where there is a historic group, meaning there's no current group, and there's a history of antibody. So what you're going to do is the same thing. Because the person has antibody, you also need to let the world know that this person has an antibody and does not have a current group. Can I have a current group? Okay, and also perform a serological cross match where possible. If they can wait, that is fine. Okay, then they will send you the sample again. You do the current group, and of course you do the antibody screening. Okay, if it is positive again, of course do panel. But because the historic antibody, you then make sure that there has to be a serological cross match. Okay, because of that historic antibody, there will definitely be a serological cross match. So once you've asked them, this person has a history of antibody, there's a historic blood group, I need a current group, then they will send you sample for a current group. If they can wait, okay, you run that sample, perform a serological cross match, issue a compatible unit. However, if they cannot wait again, once they cannot wait, what you then have to do, because you have only historic group, what you then need to do, of course, is to issue O positive or O negative, like we've said, okay? Then, and of course, prioritize. For example, if the person has antibody little e, you make sure that you try to select a blood that is little e antigen, little e negative, and issue to that patient, okay? So once again, once you've asked for any of these questions, if the ward cannot be able to assist, if they cannot be able to wait for you to determine, okay, whether you are going to issue a group specific or not, the default decision to make is to issue blood group O, either positive or negative. But you make sure if the woman within bearing of age, that you issue blood group O negative, okay? Because of, especially when you don't know that person. Let me take this again. So once the person has a historic blood group and has a historic antibody, what you do is the same thing. You don't have a current group, obviously, so you ask for a current sample. If the ward can wait, what you do then, you process it. If everything is fine, you perform a serological cross match, you issue the blood. Happy days. However, if they cannot wait for any reason, you then have to default, okay, to O blood group, okay? Then whether it is going to be positive or negative is dependent on the patient involved. Is this a woman within bearing of age, or is it a woman above bearing of age, or is it a man? Okay, now that is what you are going to do. So what I'm trying to tell you, each of these scenarios is based on your negotiation. So you kind of negotiate with the ward whether they can wait or they cannot wait, and all of that. Another scenario, which is the fifth one, is when you don't know the patient at all. So you are going to issue the blood, okay, as emergency. So when you are issuing it, you have to default to O positive or O negative again, depending on the patient. Is it a man or is it a woman above bearing of age, or a woman within childbearing age? So what you are going to do again is that once you issue that O negative or O positive, you do your best to ask them to collect 2 samples at least 10 minutes apart, okay, and send to you, okay? That way it will help you to also group this patient before them transfusing the patient, because if they transfuse the patient, that donor sample can affect the blood group, okay? So now that you've known each of these scenarios, if you go for interview and they ask you about major hemorrhage activation, you need to know something. So once a major hemorrhage is activated, there's what we call pack 1, there's what we call pack 2, there's what we call pack 3, okay? Now, I'm going to tell you what they are, but again, I'm going to also mention what you can see in practice. So once you see pack 1, okay, once a major hemorrhage is activated, that activation of major hemorrhage demand that you give pack 1. Pack 1 comprises 4 units of red blood cells and 4 units of FFP, okay? But remember that with the FFP, it is frozen. Don't forget that. So because it's frozen, you have to thaw it, and it might take maybe up to 30 minutes for you to thaw it. So what you are likely to issue quickly will be the red blood cells, and you start thawing FFP. Now, once they have done that, they may reassess the patient by sending a full blood count sample. Depending on the situation, this is a clinical decision on their own. If they continue, because once a major hemorrhage is activated, until it is stand down, until they call you and tell you they are standing down on that very major hemorrhage, it is still continuous, okay? You might move into part 2. Okay, so once they have given that 4 units of red cell, 4 units of FFP for some reasons, okay, they may decide to move to part 2. And on that part 2, what part 2 include is 4 units of red blood cell, 4 units of FFP, but on this occasion, then you now have 1 unit of platelets, okay? Now, sometimes after that, you can now have part 3. In that part 3, again, the same procedure. The only thing that will then happen, 4 units of red cells again, 4 units of FFP, and then you might have cryoprecipitate added. But in all this thing that I've said, so I've mentioned with part 1, 4 red cells, 4 FFP, part 2, 4 red cells, 4 FFP, and 1 platelet. Part 3, I've mentioned 4 red cells, 4 FFP, and cryo. Now, let me tell you this way. So when we say 1 dose of FFP means 4 units of FFP. 1 dose of cryoprecipitate is 2 units of cryoprecipitate. So once I'm saying this, I'm trying to say that in a case of emergency, then when you are going to pack 1, okay, you are giving 4 units of red blood cells, you give 1 dose of FFP. You see it now. When you come to part 2, you now do 4 units of red blood cell, 1 dose of FFP, of course, and 1 unit of what? Platelet. Then when it comes to part 3, you now give 4 units of red blood cells, okay, 4 units of FFP, 1 dose of FFP, and then of course 1 dose of cryoprecipitate. But let me say this, even though we have mentioned these parts, I want you to know that it is a clinical decision to decide. So even when they have activated a major hemorrhage, yes, you can issue 4 units of red blood cell. They may end up using just 1 unit. They may end up using just 2 units. Sometimes they may not even use any. So it depends. They may not use the FFP. They may use the FFP. So it depends on the clinical decision. But from the laboratory point of view, what is activated? Pack 1 is what I've told you what it means. Pack 2, I've told you what it means. And pack 3, I've told you what it means. So if you go for interview and they ask you, in a case of emergency, which blood are you going to issue, please link all these things into major hemorrhage and also link it into whether pack 1, pack 2, pack 3, and all of that. Okay, I hope that makes sense. And again, until you have heard, we have stand down, the major hemorrhage activation continues. So once they've done all of this, give this person red cells, give FFP, give all of this, and they think that the whole thing is subsiding, the major hemorrhage is subsiding, then they can now call, say they are standing down. So you then of course note the time they are standing down. So that your form you are filling will comprise what you have issued, okay, the detail of the patient, like I've said, and all of that. Then you also mention when they activated the major hemorrhage and also when they stand down, okay. So all of this is after everything will be investigated to see how that protocol went, whether there's a breach in the guideline or whether everything was followed the way it's supposed to be followed. But I can also mention this, please, which I forgot to mention. I've already said it on my previous video anyway. In a case of emergency, when you are issuing blood, whether it is unknown patient or whether they cannot give you a current group, as the case may be, do your best where possible, to get a C-deck neg with big C, D, big E, and K negative blood. But remember, if it is O positive you are issuing, the D is already positive. You try to see if you can get big C, big E, and K negative blood. And again, I've said, if in a case of emergency, any antibody that the patient has, if they cannot wait, please see if you can select that antigen negative when you are issuing that blood, even if you are not doing a serological cross match. Okay, I hope this makes sense. So this is, here you go, when you talk about major hemorrhage activation protocol, what to do in a case of emergency and all of that. Please, the essence why I'm making this video is this particular topic is so that when you are, because this is a common question, in a case of emergency, which blood will you issue? Please, try to go beyond O negative. That is generic. That is a default. For example, if you don't know the patient, or like I've said, but if you know the patient, there are a lot of things you can do. So the question is, do you have a current group? Or do you have a historic blood group? Do you have a current? Is there any antibody or there's no antibody? So those things will help to form your decision. I hope this makes sense. So here you go. But there's a question I would like to ask you as I recap this: is that what in a case of emergency and a patient is on anticoagulant? Remember that if a patient is on anticoagulant, the person will bleed heavily because that anticoagulant is already preventing the blood from clotting. So in a case of emergency, when a patient is bleeding, what are we going to do? I will tell you that on my next video, okay? Where we look at anticoagulant reverse in a case of major hemorrhage. Okay, so I'm going to tell you guys what to do. However, but yeah, this is the end of this video. So next time I'm going to look at what to do in an emergency when major hemorrhage is activated and the patient is on anticoagulant. We're going to look at that in detail. Then after that, I am to go into the guidelines. Okay, so if you have any question, can you put it on the comment section? Thank you very much till I come back away again. Bye bye.